Good evening, everybody. Thanks, Dr. বিশ্বাস, for the invitation, and also one of our guidance student from the district. So next few minutes of time, I will be talking on some problems we face as a nephrologist for treating diabetic patients with some amount of renal dysfunction. Diabetic patients have not a very easy life. They have so many comorbidities, loss of life takes more chances of death, they have to earn more because of the morbidity and the mortality associated with this significant disease. Up to 1993, there is a process and there is a desperate attempt to control the blood sugar was the only attempt. Just because to reduce the blood sugar level, after 1993, last 30 years back almost, we started to know that we need to control diabetes not only for the loss of mortality, also to reduce the end organ dysfunction like nephropathy, retinopathy, or cardiovascular diseases. But in last 15 years' time, we have also known that only glycemic control may not be enough. We need some additional therapies which is not targeted directly to the glycemic control, but still have some impact on the life of a patient with diabetes, some amount of renal dysfunction or some amount of the cardiovascular morbidity. Like this patient, the 50 years male with the type 2 diabetes for last 10 years with adequate diabetic control with HbA1c of 5.5, blood pressure control is okay. But the problem is serum creatinine is 1.6 with an estimated GFR is almost 52 ml, slightly low, and urine albumin creatinine ratio is 800. So what should be the perfect approach for such patients to reduce the mortality of this group of patients? That I have already told that 1993 to almost 2008, these all studies have been targeted towards the glycemic control to achieve the goal of the end organ damage effect impact. But additionally, nowadays, all of us probably has changed our practice for such patients. Whenever they come to our clinic, we ask them to do 2 additional tests, that is a creatinine value which is utilized for the estimation of the GFR and urinary protein test which is estimated to be urinary albumin creatinine ratio. That is also the recommendations. You should test an ACR. We should get an urine analysis to get an idea how much protein is passing in the urine and how much kidney is functioning, that is measured by in terms of the GFR. So why this is so? Because if the patient is an albuminuria, he has more chances of death. The terminology of the albuminuria has been changed over the years. Initially it was a micro and macro, so confusion was a micro protein or a micro amount. So that these things has been changed. Now it is called if it is less than 30 ACR, it should be normal, moderate or mildly increased, moderately increased 330 to 300 and severely increased. That is the terminology that replaced the old micro and microalbuminuria. Any patient who is having a proteinuria in terms of microalbuminuria or a macro, he has a more chance of death. He may be diabetic, he may not be diabetic. You can see the blue columns are for the non-diabetic patients and the red columns are for the diabetic patients. Amount of the proteinuria associated with the mortality, you can see the mortality is lowest in this quartile and this is highest in this patient is diabetic and is proteinuric, and more proteinuric, more chances of death. So every diabetic patient is converted to the diabetic nephropathy. Suppose in a patient who is a diabetes and having no kidney disease develops a microalbuminuria in 2% per year and there is a 1.4% increase in the mortality. If a microalbuminuria patient becomes overt albuminuric, every year is a possibility is 3%, and chances of death also increases by 3%. If a microalbuminuric patient at the same time causes a loss in the GFR, there is a 20% chances every year of increasing mortality. So if a diabetic patient develops a proteinuria and a loss of GFR, there is a more chance of death in terms of cardiovascular disease, death in terms of kidney disease. So the identification of this presence of these 2 factors are very important in the life of a diabetic patients. You can see what I have already told. If the patient has a proteinuria, more chance of death. If the patient is having a low GFR, even more chance of death. So it is a recommendation for any diabetic patients, particularly type 2 diabetic patients, which you all see to test for this albuminuria and estimation of the GFR by using simple formulas to assess the mortality risk. And this is more important if the patient already develops a disease. That's a recommendation. You should check every 6 months time for such patients. Instead of which patient who has not developed the disease, you can check it in once in a year time. But this is not so simple. You can see this is the diabetic patient's proteinuria trajectory. Ideally, I have told that the patient is diabetic. After some time, he or she develops a proteinuria. That proteinuria worsens with time, and after some time, there is a loss of GFR, and after GFR loss, there is a kidney failure. But significant number of this patient, around 25 to 30% of the patient, if you diagnose them, treat them, there is a complete reversal of the proteinuria, and these patients who do not recur, there is no recurrence of proteinuria, they live more. So there is always a possibility to identify a high risk proteinuric patient from a low risk proteinuric patient, because the patient with diabetes, if he develops proteinuria, worsens in spite of treatment, is a bad diabetic patient. A patient is having a diabetes with a proteinuria which reverses with simplest therapy like ACs and ARBs, the good diabetic nephropathy patients. But some patients, due to genetic factors, you can see this rapid decline of patients. Some young patients we have already probably have all seen this patient develop a diabetic nephropathy, retinopathy, cardiovascular disease, worsens like anything, doesn't respond to treatment, die early even due to the best of the treatment. Probably genetic factors will act on this. And there is a significant number of the patients who doesn't follow any rule. The diabetic kidney disease patients who are non-diabetic nephropathy. Means they have a disease, maybe a tubular interstitial disease, may have a pyelonephritis, infarct, or maybe so many things that's in the disease. We call it a diabetic kidney disease. So the proteinuria detection is important to identify the good patients, the bad patients, the most treatable patients, and wherever treatment is slightly different such patients. So doing a urinary SCI test is important. Second is the estimation of the GFR. There is all formulas are available, but I am giving one or two lines on each. Initial classical formula is a Cockcroft formula. You can see that is utilized because it has been studied in a very small group of patients, only hospitalized patients. That's why they are not very useful for patients of ours, like a diabetic patients with a creatinine of 1.5. They are useful in terms of assessing your drug dosage, because many of the drugs in the renal clearance, and you have to reduce the dose according to the renal clearance, and all the product monograph utilizes Cockcroft formula. So whenever you are using the drug, that is helpful in this formula. Second, part 2, this is the MDRD formula, this is the CKD API. MDRD has been studied on the patient's GFR of less than 60. Compared to the API formula, which has been studied in more high-percentile populations, and they have a GFR of more than 60. So one liner is that Cockcroft formula is useful for assessing your drug dosage. MDRD formula, when your GFR is less than 50, it is very 60, very accurate. When your GFR is above 60, then the CKD API formula or CKD API formula is good for everyone. So whenever a patient comes to you, test for albuminuria, you assess for the GFR, you can put it in your mobile and assess the GFR, and accordingly you can stage them, because KDIGO and the world guideline have given us to stage them in terms of GFR and the proteinuria. You can see this is G1, G2 according to the GFR, and this is the proteinuria, and you can put the patient like our patients in the exam. This is the CKD heat map, and that's why you can know how long you have to follow up, how frequent follow-up is needed, when you have to refer the patient to a specialist, when he needs an advanced care, when he needs some hospitalization, like that. So whenever a patient comes, creatinine of 1.5, GFR of 52, proteinuria of 800 milligram, you can put him or her in this roadmap, and so the treatment becomes easier. So if a patient with this idea of proteinuria and the kidney disease, if the patient doesn't have any kidney disease, chance of death is much lower compared to the patient who has a both loss of GFR and the proteinuria. So what to do? These guidelines, probably in such group of patients, your diet control, exercise control, smoking cessation, weight reduction may not be enough. Your lipid management, glycemic control, blood pressure control also may not be enough. In those situations, you need some additional treatment which is not directly towards the glycemic control, but may have mortality benefit. Here comes the concept of this pillar-based approach. This is glycemic control, this is blood pressure control, lipid management, or other dietary management. You need a RAS blockade, maybe an SGLT inhibition, maybe a non-steroidal amiloidosis. So these pillars, initially, these pillars are also targeted towards the RAS blockade, which typically acts in the afferent and this efferent artery, directs them and causes a loss in the decrease the intracranial blood pressure, so hyperfiltration reduces and ultimately kidney is protected. It also acts at the tissue level to prevent the fibrosis. At the same time, if you use this SGLT inhibitors, you know this causes an afferent arterial inflow, reduction and reduces the intraglomerular pressure, so prevents the proteinuria. It also prevents by other action, it reduces maintains the GFR and is anti-inflammatory actions also. Third pillar is this MRAs or these field renal non-steroidal MRAs. They probably act mostly on the tissue level to prevent the fibrosis and inflammations, and the GLP-1 analogs there is not in the tissue but mostly on the systemic level to reduce the diabetes, to reduce the obesity, to reduce the lipid, and people to benefit in protecting the kidney and heart of such patients with a GFR of 50 and proteinuria of 800 milligram. So Raj Bucket has long been included in the recommendations that all patients of the kidney diseases of diabetic kidney disease should be prescribed the ACEs and the ARBs. They act by different mechanisms, I have already told. They cause a slowing in the progression of the kidney disease in such patients. So lots of evidences are there. ACEs were there in the market long before and they were tried. Then ARBs were there after 15 years. They have been tried. As they have a different time span, there will hardly any head-to-head comparative study between the ACEs and the ARBs. But they have told that they are better in comparison to the placebo. These all trials are against the disease and against the placebo treatment. They have told practically is best. You can see this irbesartan is better than placebo. They can see this irbesartan is again better than placebo. Losartan is better than placebo. Irbesartan, okay. So all these drugs are better than placebo. So diabetic kidney disease should get an ACEs and the ARBs. Alone is not efficient. So there has always been a head-to-head comparison or a combination versus placebo therapy. They suggested that yes, one is not enough. Maybe they are equally effective. Combination works better in terms of the RAS inhibition, but at the cost of the side effect, particularly loss of GFR and development of the hyperkalemia. So these are all things. With the ACs, you can block the 55% of the RAS systems. With the ARBs, you can block hardly 60 to 65% of the RAS system. Combination, you can block more